I do want to take a quick moment here because I know this is one of the things that we're trying to emphasize as interventionalists is to talk about radiation protection. In this room, I think in most of our labs here, we have the EGNES complete. So the complete setup here is you have, not only the drape that's built into the table, but a big caveat to that is that it adds about 100 pounds to the table. So we live in Cincinnati. We've got a lot of thick fellas around here. And so sometimes we kind of have to juggle that a little bit. And it also comes with this, the complete comes with this shield. And then I don't know how well you can see, maybe I can adjust this, but EGNES also has this kind of, this is why they call it the nest, but you can see that she's kind of tucked in there, and it also gives protection for those around. We use this room for our structural cases as well. This is built to be a hybrid room. And so people that are in anesthesia or doing images are okay with light lead. I'm currently lead free.
Yeah, you're looking awfully thin. The panel was commenting on that. So tell me your level of comfort. I mean, you're really appealing to me on this one. The level of comfort. Yeah, exactly. Very spelled. The level of comfort you have with going lead free. Completely lead free, and I noticed that some people will keep their thyroid collar on because of the scatter with egg. Are those zeros? Are those all zeros? I can't tell.
Those are zeros. I'm currently on the monitor, and so far, I mean, we've only had a little over 3 minutes of fluoro time with a total of 48 milligrade. So again, we don't expect much on this one, but I will say that in my usual room that I work with to do CTOs and complex PCI and stuff, I also go lead free in that. I used to wear light lead until that got recalled, unfortunately. But since that, I've been kind of messing around with things and wearing a badge. We do have live dosimetry as part of it. And I'm wearing one on my left hip here. So that's, the closest to the source and all that. So if you're going to read something, that's where it's going to read. I think that orthopedic issues are certainly kind of a lot of our forefronts, especially with the aging interventionalist workforce. But for someone like me who is relatively younger, and I like to think that I have, I have higher cell turnover than like Dean and Tim and some of our other guys here, that the cancer risk is also not something to shy away from. But I feel comfortable with this. One of the things to get adjusted to is, I do jiggle a lot more whenever I'm not when I'm advancing equipment and stuff like that. So that didn't help and stimulate some weight loss on my end too.
So the clinical data on ag is really very compelling. 92.5% to 98% reduction in radiation. But those data may even be meaningless because I think with these ERPDs, the idea is you getting facile with it, you becoming expert on your setup. You can even get, with egg, you can even get greater than 98% reduction. And that's actually what you're seeing. Now we'll see how the case goes. But right now, at least based on real-time dosimetry, and I'm guessing you're using the RaySafe badges, which I don't think you do egg without the RaySafe badges or whatever real-time dosimetry you're going to use. You're getting absolutely zero radiation. And that's the goal here. The goal is not, every case you can have a little bleeding of radiation, but the goal is zero radiation to make it absolutely the safest lab possible.
David, would you?
Yeah, and what I find over the course of the day, because whenever I'm in for a whole day, I don't reset my badge between cases.
Right, exactly.
And so
you get your cumulative dose.
Yeah. The entire day. Yeah. And it typically for me is about 1, maybe 1.5 millirem. It's really unusual for me now that, EGNES has been they've been very responsive to feedback. And I think regardless of what protection device you have, these companies at this point are still relatively small and relatively flexible, and they're great with working with. But yeah, we're able to kind of modify things. And so even at the end of the day, like, you know, I've done as many as 5 CTOs in a day, and I've come away with like 2 milliram. And so the threshold is 5,000 a year.
Right.
So there's almost no way for me to get that unless something's egregiously wrong.
Do you guys add? I see myself. I have Rampart, and I do most of my cases with Rampart. But I have to add rad pads. Sometimes I find a leak.
I think the rad pads are. Let's see. Do you have them?
Yeah, I also have rad pads here.
Great.
That come for the gap. There's one, I don't know what brand it is, but there's a special cutout just for the access.
Yep.
Mm-hmm.
And so you don't have to like mix and match a bunch. And so this is great. And this also works really well for the radial approach. Because if you think about it, I don't know which camera I'm at, but if you think about it, when they're splayed out to the side, there's a gap here.
Right.
Yeah.
And so this specific one helps cover that gap, that little tunnel of radiation there. And again, being able to monitor in real time. And again, you know, I wear it right here, as close to the source as I can to fixate on my scrubs. And so being able to do that in real time has really been wonderful.
We think about radiation exposure. There's a number of young early career and fellows in the audience. Talk about the importance, given the contemporary studies, the SCAI issues, why this particular issue is so important, and why young physicians, young women and men getting into this field should embrace this radiation protection opportunity and the strategies.
100%. He's not wearing lead. Nobody in the room needs to wear lead with this technology. I was paralyzed in my hospital room after cervical cord compression when Jared and Santiago Garcia, our structural guy, said, we tested 3 systems. We like this system because, in particular, Jared can see the patient, he gets access, and you're doing hundreds of CTOs a year, wants immediate access. One thing I would highly recommend for you young guys, even though the lead has gone from 30 pounds, which I wore from 1982 to about 2005 or so, and it took its toll. My partner, Tom Broderick, just had cervical spine fusion for cord compression. Chuck Abbott-Smith, who hired both of us, has had 4 separate spine operations. If you read the 23 survey from SCAI, 60% of you guys out here in practice 15 years are going to have a cervical or lumbar spine injury. Okay? I mean, it's serious. And you can do crunches. John Douglas at Emory was probably the best guy I knew at doing hundreds of crunches a day. And you can try your best to build your body. But the obvious thing is take the lead off. But posture is another issue. Okay? Ergonomics.
Okay.
This. All right, Jared, but we try by the big screens, putting them up. We try not to be locked in a position of neck flexion, but you cannot run away from this. And I think the hospital system, and my event happened February of 24. The CEO, the chief, actually chairman of the board, said that our ROI on this, which is about 175 per lap when we put it in, I'm not sure what it is now, and we did 10 laps, that it's called workplace safety and liability. And the other thing that's so important is if you're not monitoring yourself in the lab, guys, you should be doing it. And I don't think any one of us had a clue how much radiation exposure we were getting on a real-time basis. And before you get an ERPD in your hospital, before they go live, make sure everybody in the lab wears these for 2 weeks and realizes what their baseline exposure is with lead. Because now when there's no lead, they say, oh, I got 0.1, 0.2 for an entire day of complex cases. I mean, this is a 90+% less than we would have gotten otherwise. So I think you really have to do that. I couldn't be a bigger advocate for obvious reasons. I'm actually back in the lab, no lead, much reduced case volume. Tim Henry doesn't wear lead. And it's hard to get some of these younger people that come out. And I think particularly women in IC who want radiation protection, they realize that they get less with this than lead. So some of them will still wear very light lead plus this. Jared, do you have any comments about?
Yeah, I mean, I think you hit several nails on the head there. One thing that is important, I think, is that what we did, what Dean alluded to, is there are really good systems out there, and what we did was we trialed them all, and we actually surveyed not just the docs but also the staff too. We all filled out the same form, and essentially whichever one won out is the one we kind of went with, and so we went with egg for a variety of reasons, in particular being able to do both coronary cases as well as structural cases. But just to also head up, I mean, how many, Dean, you don't have to volunteer this information, but how many docs do we know that stopped wearing their radiation badges? See, I just wear mine when I lanyard here, but stop wearing these or keep it in the closet or in a drawer because the reads were too high. And even if you're wearing a lot of thick lead, if you're exposed to that much radiation, some of it's going to penetrate. And so not just the orthopedic issues, but I think also, the increased cancer burdens. I'm just going to assume that I'm going to have cataract surgery at some point. I mean, there are tons of costs to this. And I feel like this is another area where, I think in very real senses, healthcare in the US is kind of exploitive of its workers. And we're always asked to do more with less, and even bring in economic considerations and everything else. But, we need to also take care of ourselves. And it's not mutually exclusive. We can do a couple things. One is that, so my wife is an orthopedic trauma surgeon, and one of the jokes is that I became a real doctor once I started wearing lead for doing my procedures, as far as she was concerned. But now she's even more jealous that I don't have to wear lead during the procedures. And, they're obviously dealing with their own issues because they both treat it and are victims of it. So I think even beyond the cath lab, there's lots of ways for us to improve this. But I think a big thing for me is, just kind of who I am, my personality. I don't feel obligated to show off or do anything fancy. And I think just doing a nice practical case where you use the information that you learn, and, even if you're biased one way going into it, feeling willing to change things on the fly based on the information that you see. And so I want to thank you all for this opportunity. Thanks for the great discussion. And I've also never really regretted ending a case earlier or it being easier than it turned out to be. And so I hope that you at least got something out of it. So I appreciate it.
Great job.